unremarkable. For our second differential diagnosis is Rasmussen encephalitis. Basis, usually it presents with focal seizures, and it also presents with hemiparesis. It can be ruled out because all patients of this disease entity were 3 to 15 years old, and our patient is 19 years old. Our third differential diagnosis is mitochondrial encephalomyopathy, lactic acidosis, and stroke, or also known as Yermelas. Basis, it usually presents with focal seizure, with lead to secondary generalized seizure. It could also present with focal neurologic deficit, which is a patient presented with left side extremities, weakness, also with numbness of the left foot. It could also, patient also have a family history of diabetes mellitus. It can be ruled out because usually in patients there is normal development, and later on they would have poor growth. The patient also didn't have manifestations like vomiting, migraine headache, and dementia. So our next differential diagnosis, our last differential diagnosis, is neuronal tumor, probably astrocytoma. Astrocytoma usually presents with focal to generalized seizure, with recurrent seizure in 6 to 75% of cases. This patient also has a high family history of malignancy, like your lung cancer and brain cancer. Can be ruled out because, as mentioned earlier, it progresses slowly, usually 5 to 6 years ang progression. Usually, it is most common in childhood and is typically it frequently occurs in cerebellum, but it could also be confirmed through your tissue biopsy. So for the pathophysiology of the patient, let me break it to you gently. So the patient has a food, based on the history of the patient has a food preference, which is vegetable salad. The patient is more than 7 years old because our patient is 19 years old. Also, the Philippines is one of the endemic areas for cysticercosis. It is moderately prevalent. Probably, patient ingested of tapeworm larvae because cysticercosis is common in vegetarians. The worm attaches to the intestinal wall, migrate through the body via the vascular system to the brain. So, let me break it again gently based on the history of the patient. So 7 months prior to admission, probably the patient larva is lodged to the different parts of the brain. So your larva preferably would dislodge to your brain parenchyma. So your cysticerci is approximately 10 mm in other sources, and according to Harrison's, it is 5 to 20 mm. It also commonly lodges into the cerebral cortex or the basal ganglia. But probably sa patient, it is usually in cerebral cortex. It is explained earlier. So it could also dislodge in the subarachnoid space in the cerebrovascular fluid cisterns. It could grow up to 50 mm there because it is not limited by the effect of your CSF pressure. It could also dislodge in the ventricular area, which are usually single lesions, and could lodge to your choroid plexus. As we all know, your choroid plexus is the one that secretes your CSF. So, the cister size are viable and induce slight inflammatory changes in the surrounding tissues. So, that would stimulate your focal seizure. That's why that is the first onset of the focal seizure 7 months prior to admission. So, also, it is mentioned earlier that there is minimum inflammatory reaction because your cysticerci carry out prostaglandins and low molecular weight molecules which decrease pre-lesional inflammation and secrete a protease that can degrade interleukin-2. So it suppresses the inflammatory response. So the parasite remains alive and undergo different stages, such as your vesicular stage, colloidal stage, granular nodular stage, and nodular calcified. So the patient penetrates arteries arising from the circle of Willis and affected by this magkosyak inflammatory reaction. The inflammatory reaction was secondary to the degradation of your cysticerci. Because still, there is still immunological attack releasing lymphocyte proliferation and macrophages, weakening your cysticerci. Then, there is occlusion to the lumen of the vessels. As mentioned earlier, the localizing lesion is in the middle cerebral artery. Your middle cerebral artery has 3 branches. So, the common site of your lesion in your cysticerci is your middle cerebral artery. As I mentioned earlier, it is 10 mm. Probably in your lenticulostrate vessel. Your lenticulostrate vessel supplies your internal capsule. So therefore, the patient has a pure motor hemiparesis on the left, contralateral hemiparesis. And decrease in cerebral, so therefore there is also a decrease in cerebral tissue perfusion secondary to vasculitis. So the infarct at the right parietal area was secondary to this reason. So the patient presents with left-sided weakness and deviating tongue upon protrusion. So that is 4 to 6 weeks prior to admission. So the patient, there is an occlusion by the thickened leptomeninges in the subarachnoid area or in the ventricular area. Still, there is blockage. Still, your CSF is continually secreted. So it progresses into compression and atrophy of the brain tissues around the dilated ventricles. So by second hospital day, the deterioration is so rapid. It could be due to increased intracranial pressure, also known as your obstructive hydrocephalus. It causes edema, therefore your brain tissue atrophies because secondary to dilation of your ventricles. That is in the second hospital day, that would lead to neurological impairment, respiratory arrest, then death. So our diagnosis is acute obstructive hydrocephalus, probably secondary to subarachnoid cysticercosis. Cerebral hemorrhage, probably secondary to cysticercotic arteritis of small penetrating vessels. Neurocysticercosis. Basis. This is the most important of the parasitic disease of the of the central nervous system. It is also a risk factor in stroke in the young. Patient is stroke in the young because 19 years old a patient. Usually, of course, in vegetarian in endemic areas including Southeast Asia. So, hidden database for Philippine literature of cases of cysticercosis. It is not rare, but it is only have 10 reported cases because of lack of facilities like your CT scan and MRI. So, 10 reported cases by 1988, 2 cases in 1961, 3 cases in 1926, 2 cases in 1927, and 3 cases in 1980s and 1984, and 2 cases in 1988. So most cysts are found in the CNS, skeletal muscle, subcutaneous tissue, and the eyes. Usually, a symptomatic period of several years before the onset of symptoms. It could also be months to years. So seizures are by far the most common clinical manifestation. 70 to 90% of cases presents with focal seizures. Seizures are usually generalized or focal with secondary generalization. May present with hemiparesis. So, a patient has a right infarct based on the CT scan. Usually, the CT scan reveals parenchymal lesions. Your CT scan is only highly specific or sensitive if you would have contrast injection of your CT scan. CT scan was 44% sensitive and 95% specific. Your stool examination, as of our patient, presence of tenia ova or prolitid is insensitive even for tapeworm carriers. EEG studies are either normal or indicate non-specific abnormalities. Thank you.